to the cloud. There you go. And Rich, just so you know, you have access. I'm recording to the cloud, so you can convert this and put it up whenever you like, whenever we have Teaching Tuesdays.
Mhm.
Uh, Dr. Dyer, take it away.
All right. Well, welcome everyone. Good evening. And thank you for coming to Teaching Tuesday. This is what we have planned today. So I heard you loud and clear that people wanted a little refresher on electrolyte abnormalities and EKGs. So I have a quick teaching slide deck on that for you that will also I'll make a PDF available for you on the Moodle, so you have something as reference. Um, that should take about 15 or 20 minutes. It'll be relatively brief as just kind of review. Then we're going to go over Scarbosa, just to give you a little refresher on that. There should be a PDF available on the Moodle as well for that one. Then we're going to take a quick stretch break. And then we're going to go into just some rapid fire EKGs. I will say that there's all different levels with these EKGs. Some of them are complex, some of them are not. Um, it really is just there for review. If you feel like you get stymied by one of them, don't panic. It's fine. But why don't we just get started? I am going to actually take my camera off so I can better focus on the screen, but I am still here paying attention to you. All right. So I'm just going to send a request to the deputy to let me
Oh, yes, I'm
share.
sorry.
Don't worry, it's all good. It's all good.
Yeah, yep, there we go.
Okay, perfect. All righty. Okay, you folks should see my screen. Benny, can you give me a thumbs up since I'm seeing you first? If you can see the screen. Okay, I see a thumb up. Okay, so this is what we're going to do first. We're going to do electrolyte abnormalities, quick review. Okay, so here are learning objectives. We're going to understand the role of electrolytes in cardiac electrophysiology. We're going to do some EKG electrolyte imbalances. Uh, this really is pattern recognition. So this is super easy. These are easy questions to get right on a test if we think about kind of focused study so that you focus on what you can easily get right. And this is truly squarely in the easy to get right. So couple of reviews, though, of electrophysiology before we get into the pattern recognition. So, remembering that potassium influences membrane potential, calcium that we've talked before also has that effect on the plateau phase of the action potential, and therefore the QT interval. And magnesium, if we were going to kind of summarize its influence, modulates ion channels, but also, as we know, kind of has some point in arrhythmia risk. Okay. So I think the one electrolyte abnormality that people feel fairly confident in is hyperkalemia, right? You tend to know the risk factors. You guys tend to know what it looks like. Let's go over a little bit of what happens, and then I'm going to start with each of them. I'm going to start to show you some examples. So anytime you have hyperkalemia, you have an increased extracellular potassium, and it induces resting membrane potential. The EKG changes you tend to see, particularly when all this now becomes intracellular, is peak T waves, widened QRS, and in severe cases, a sine wave. I think we know kind of the common reasons why you get hyperkalemic. Renal failure is probably the largest ones. People on ACE inhibitors, so that would be captopril and drugs like that, lisinopril, are at risk of ACE inhibitors causing hyperkalemia. In addition, there are some other drug interactions. So, for example, if I was writing a test question about risk factors for hyperkalemia, I might include a patient on an ACE inhibitor who then had some other medication added to them and then got dehydrated. Those are typically like the perfect storm for patients to get hyperkalemic. Can you guys think about other reasons why someone would get hyperkalemic that is not on that slide? Don't worry about being wrong.
Would increase like vomiting
Okay.
with that?
So it's a really good thought. So not so much increased vomiting, but if you had increased vomiting with dehydration because of low kidney perfusion, then that absolutely could potentially cause it. All right. Any other ideas? Let's say someone had an opiate overdose and they were on the ground for a day. Would that patient have a low potassium or a high potassium?
A high potassium.
Right, right, exactly. And the reason is that muscle breakdown. So if someone's in rhabdo, having a lot of tissue breakdown, they can have a high potassium. So finally, I'm going to have you guys look this up, right? So there's a syndrome and it's called BRASH, BRASH. To do your own learning, I'm going to have you look that up at home because you could just do a quick Google search, um, because that way you'll actually remember it a little bit better than my just kind of going over it. So, and that's another syndrome that particularly in that kind of combination of medications, beta blockers, calcium channel blockers, decreased perfusion really increases your chance of hyperkalemia. So let's get to some hyper K stuff. So this is actually looking at some precordial leads, right? You see kind of the classic peaked T waves, but the other sign is a small or indiscernible P waves. So you have these peak T waves, but also if you're looking at that EKG, look for these really small or hard to find P waves. And then if we go along on this progression, we have kind of the first tracing, which is a normal potassium, and then you're getting some peak T waves. People will frequently describe those peak T waves as looking like the Eiffel Tower, so having that kind of sharp type of peak on it. But the other thing you'll see in that third tracing is the flattened P, and then that kind of lengthening of that PR interval. But you'll also see on the fourth one, right, that fourth tracing, the widening of that QRS. And then on the fifth tracing is that sine wave. And on the thing a little bit on the right is what they call mathematical sine wave. And that is just a visual remembrance of what that sine wave pattern looks like. And if we were going to look at an EKG as kind of classic, right? And what do you guys notice about this EKG in terms of the peak T waves? How about in the distributions of leads?
It doesn't seem like they're as high in V1 and V2.
Yeah, so V1 and V2 don't look that particularly remarkable, nor does lead one or lead AVL, right? And if you looked at AVR, it's actually inverted as well. So I put this tracing up because it's still a hyperkalemic EKG, but don't get too thrown off by the fact that those types of hyperacute T waves don't 100% show up in all the leads. But you can see this in this EKG, the predominance is those really high hyperacute T waves. And then what are we supposed to look for in terms of the PR or the P waves?
Want to look for small P waves
Yeah,
in V5 and 6.
yeah. And I think even when you look at the rhythm strip, I think you really can't see any P waves in this one. Maybe if you look at Yeah, it's really hard. I can't find any. Okay. So that's hyperkalemia. That's the one that everyone's good at, right? So let's next go to the ones that people struggle a little bit more with. Hypokalemia. Okay. So what happens in hypokalemia is you have increased membrane excitability and delayed repolarization. The EKG changes are flattened T waves, something called a U wave, which you might have heard of before, but if you haven't, we'll show you some pictures of it, and then ST depression. Now, why is hypokalemia bad? Similar to how hyperkalemia can cause that sine wave, hypotension, and then potentially arrest. Hypokalemia can also cause significant ventricular dysrhythmias, and it can also be a problem, a concomitant problem when someone has DIG toxicity. So if they have DIG toxicity, too much DIG, and have a low potassium, that can usually spell trouble. Can you guys throw out some reasons why you'd get hypokalemic, where you get a low potassium? There's a bunch of them. Benny's shaking his head. Well, Benny, you had a good answer for the last one that applies to this.
So increased vomiting.
Ah, fabulous.
Boom.
Okay.
All right.
Boom. Okay, you got it. All right. Yeah, so anything that is kind of increased volume loss, increased vomiting tends to be kind of the classic one. Anytime you have also a lot of fluid losses from diarrhea, but increased vomiting would be one. Um, think about medications that might make you hypokalemic. Think about a heart failure patient.
With furosemide or
Yeah,
Lasix.
furosemide or Lasix, so the standard loop diuretics, right? So furosemide, Lasix, etacrinic acid, there's a whole torsemide, there's a whole bunch of other diuretics that can cause, in the loop diuretic family, cause hypokalemia. And if we think about a diuretic that's also used as an antihypertensive, the big one would be hydrochlorothiazide, right? So those are the drugs that really kind of put you at risk in addition to other kind of fluid or volume losses as well to give you hypokalemia. So this is kind of a classic EKG for hypokalemia. So I'm already telling you the diagnosis. Now, I want you to go through the EKG and guys can take a minute and look for supporting evidence. Look for things that support that this is a low K. Let's say you don't have their labs.
Well, there's definitely flattened T's.
Okay, definitely flattened T's. Okay. I saw Abe come off mute, but then I didn't hear him.
Yeah, I said the same thing, flattened T wave. My
Uh,
mic was mute.
oh, okay. Okay. All right.
Um,
Anything? Go
I was
ahead.
gonna say, well, looks like V1, V2, V3 have, or V4, 5 some depressed ST
Yeah, absolutely.
segments.
hmm Now, there's another wave that we see kind of classically in hypo K.
The
Is
U
that
wave,
the
right?
U wave?
Yeah.
Is that
Anybody's?
what's in V2, 3, and 4? Is it the U
Yeah.
wave right before the P wave?
Yeah, it's a little hard to, it's doesn't show up as well in this tracing. Is probably not the best example, but the U wave actually can also get buried uh, in that QRS as well. I have to say, particularly if you look at V5 and V6, it does look like it's a fairly distinct P wave. And if you look at the rhythm strips as well, I think there's a fairly distinct P wave. So sometimes the U wave gets absorbed in the rest of the tracing. All right, so a couple of visual representations of hypokalemia. So the first one, so normal potassium, remember we talked about normal levels for potassium, around 3.5 to 5. A potassium of 3 would be low. A potassium of 2 would be fairly profoundly low, and puts the patient at significant risk of arrhythmia. And you can see on this one that in some ways the U wave is almost more prominent than the T wave in that, and you have that kind of distinct T wave flattening. And then we get down to a potassium of 1, which is really hard to survive, right? And you have really much more of a prominent U wave and a barely discernible T wave. Okay. So our next electrolyte abnormality is hypercalcemia. So that would be an elevated serum calcium or ionized calcium. The hallmarks of this electrolyte abnormality is a shortened QT interval. We talk about QT intervals usually as prolonged, but this one is actually shortened when you see a patient with hypercalcemia. Reasons to get a relatively high calcium are a little less common than some of the other things that impact potassium. So your parathyroid gland, so any type of abnormality of your parathyroid gland can cause hypercalcemia. And they have kind of a mnemonic to remind people of that high calcium, and it's moans, groans, and fragile bones. Tends to be one of the more common mnemonics. But these folks actually with relatively high calciums are at high risk of getting kidney stones, and the other and having other kind of bone remodulation problems as well. The other big patient population that we see this in is malignancies, right? Sometimes patients' first presentation will be getting noticed to be hyperkalemic, and then we do some further searching, can't find a good reason for their elevated calcium, and then end up finding some kind of cancer. And that is true for both solid cancers, so things like lung cancers tend to be the more common ones, specific types of lung cancer, but you can also see it in leukemias and lymphomas as well. Physicians deal with this fairly aggressively if you're in the cancer world, and do a lot of hydration, but they'll actually also sometimes give people loop diuretics, because just like it can make you pee out your potassium, it can make you pee out your calcium. So this is what it would look like. So you see in this EKG, there's pretty much a P before every QRS. But if you kind of go back and look at our hallmarks, right? So our hallmark is that shortened QT and that ST segment. And they kind of have some nice little arrows to kind of show you that. But if you really look at that ST segment, it's particularly short and sometimes has those kind of sloping waves to them.
Can I ask a question?
Yeah.
Because I was, while you're talking, I was looking at the cardiac action potential. So in phase 2, where it says calcium and sodium help to increase the plateau phase, so you can get during the depolarization, like it's known as the longest phase. So that's the ST segment. If it's making it last longer with calcium, how come if you have more calcium, it doesn't cause it to lengthen even more, but rather shorten?
Shorten, yeah. I think it has to do with the fact that you have more available calcium, and then you have more receptors available to take that that calcium, and it's just going to shorten out the potential.
Okay.
Because you have more receptors than you use, right? So there's tons of receptors. Not all of them have something landing on them, right? And therefore you can, but all of a sudden you have exogenous, like if someone gives someone extra IV potassium, those other receptors that are not normally working are now invoked. So now they're working. So in some ways, we're not set up well for dealing with abnormalities in electrolytes, right? We should be set up a little bit better. All right, a couple of, to remind you, just a couple of other causes. So we talked about that malignancy. There's something called milk alkali syndrome, which I won't have you focus on too much, right? Vitamin D toxicity. Occasionally you'll hear about people getting too much vitamin D, usually additives in milk. A disease of bone remodulation, which is called Paget's disease. We talked about thyroid disease, prolonged immobilization, like someone who is in bed for a long period of time and they start to have bone resorption. Some types of granulomatous diseases, and that's kind of an all one, but also thiazide diuretics can cause it. Okay. So the next one is low calcium. Okay. So that's going to give you a long ST segment and a prolonged QT interval. There is also, similar to how we talk about some electrolyte abnormalities causing torsade, this is also one of the other ones that also puts you at risk for torsade. So that's hypocalcemia. Let me show you a couple pictures, right? So we have hyper, right? And then we have something normal in the middle, and then we have hypo, so that very long QT interval. Okay. The next one we're going to get to is magnesium. High magnesium levels are relatively uncommon, but they can cause prolonged PR and QRS, and in severe cases can cause an AV block. Reasons to get a elevated magnesium level would be exogenous magnesium, so someone just taking a large supplement. And because magnesium is excreted renally, people who have renal failure can occasionally get a elevated magnesium level, right? Low magnesium is actually much more common. And the EKG findings are fairly prevalent, right? So that is prolonged QT, and that also predisposes you to torsade. Sorry, that's a tongue twister. If any of you are furiously writing all this down, if you do that for your own education, that is absolutely fine. However, I will get to the deputy the PDFs of this, so you don't feel like you have to write everything down unless you feel that that really kind of helps you learn. So it's really completely up to you. All right. QRS changes with low magnesium, so hypomag. You can potentially get this QRS widening, QT prolongation, and flattened or inverted T waves. Can you guys think of anything else that would give you a low magnesium? It's actually super common to get a low magnesium. Less common to get a high one, but super common to get a low mag.
Is it pregnancy?
Pregnancy? Not so much, even though we use magnesium for eclampsia and preeclampsia in pregnancy.
Would it be dehydration
Yeah,
or malnutrition?
yeah. Oh, sorry, I heard a bit of an echo.
Sorry, my audio is a little wonky on this.
That's right, Jay. Absolutely. So malnutrition is probably the main reason that you're going to get hypomag. So people who are just protein calorie deficient, or particularly people that drink a lot of alcohol, right? Tend to have low magnesium. And where it becomes a problem is someone who has both hypomag and hypo-K is really kind of a setup for torsades. Okay. When we're looking for low potassiums and looking to replete them, we will frequently actually check a magnesium, because if someone has a low potassium, particularly from malnutrition or from alcohol, there's a fairly good chance that they're going to end up with a low magnesium. So really a big risk factor for that patient population. And this is what we're worried about, right? Anybody want to take a look at this one? And should be a quick visual recognition of this.
Looks like a
Is it
sinus rhythm.
torsades?
Yeah, sinus rhythm with a prolonged QT, but a P wave before every QRS, and then goes into torsades as well. Where do you see the twisting? If we were to count backwards from the end, where would you view that twisting point to be?
If you're looking at between V2, V5, like right where V2 ends at V5.
5. Okay. Yep. That's where it seems to kind of twist. And then it also has kind of different amplitude as well. All right. So a quick summary, right? So hyperkalemic patients, so we talked about the peak T waves, but also loss of PR interval, risk for sine wave, and risk for eventually asystole. Hypokalemia, the classic U waves, the ventricular arrhythmias, as well from that. Hypercalcemia, a shortened QT, low risk for torsades. Low calcium, long QT. So basically anything that causes a long QT, high risk for torsades. And hypomag, probably the most common one to cause this, is prolonged QT into torsades. So another way, I like this slide because it kind of puts it all together all in one place and kind of gives you a visual. So the visual on the side of this slide is essentially someone's finger, right? So hypomag, you think about kind of causing that depression of that ST segment. Hypermag, you think about someone kind of pulling up that T wave. Hypocalcemia, you kind of think about someone directing the T wave to go long. And then hypomag kind of again pushing that T wave down. So just a couple of quick ways of visually remembering if that's helpful. All right. So a couple of management pearls. I know we don't really have electrolytes other than magnesium, but in general, we think about in most emergency management really kind of correcting electrolytes before we start thinking about a lot of arrhythmic therapy. Paying attention to patients who have renal disorders because you can get a lot of problems. IV calcium for hyper-K, mag for torsade. And I think the other final thing would be if you can't find it if you don't think about it. So you can't, unless you think about electrolyte abnormalities, you're not going to be able to find them on an EKG. And then a quick couple of reviews for the Ks, right? So we have hyper-K with a peak T, hypercalcemia with that flattened T wave and a little bit of a U wave, hypocalcemia, really that flat T wave, and then the shortened QT, and then the prolonged QT. All right. So that was our warm up. I'm going to stop sharing. I'm going to give you a 5-minute stretch break, and then we're going to come back into Scarbosa. See you in 5 minutes. Okay, why don't we start to gather back? So our next,
MD1.
yeah,
I apologize. Before we move on to Scarbosa's criteria, can I just ask a quick question regarding electrolytes?
sure.
Um, like in reviewing it, it says is chloride ions, like the negatively charged chloride ions that come in during phase one, is that not like a significant thing? Is that why we don't talk about it much versus
Y-
the other
In
electrolytes?
Yeah, so super good question. Yeah, because chloride's in the mix, but it really is not a significant thing in terms of EKG impact on from electrolyte abnormalities. Now
Okay.
there actually are conditions where um, people get a hyperchloremic um, metabolic alkalosis. One of the reasons why it used to be we never gave lactated ringers and we always just gave liters and liters of normal saline to people who were dehydrated. But what they actually found is that ended up causing some more long-term problems with excessive chloride, but also with metabolic alkalosis. Um, so that's when we frequently, for someone who's just kind of primarily dehydrated, we've actually frequently moved to just giving them Ringer's lactate as well. Because we found that, after probably about after a liter, liter and a half, it's not a big deal. But if you're starting to do large volume resuscitations on folks, then you're going to potentially get into trouble. But that's a good question, JJ. All right, let me share the screen again. So we're going to do Scarbosa. Anybody want to remember why we do Scarbosa? Is there a particular thing that we would apply it to?
To rule out a STEMI in the presence of a left bundle.
Right. So can folks see my screen? Okay.
Yeah.
Yeah. Okay. Perfect. Thanks, Dave. All right. So this is a PDF that should be available to you. It's just really just a quick review. So what we're going to do is we're going to do the modified Smith Scarbosa, just as kind of a good background, and then we're going to take another stretch break and then go into just some rapid fire EKGs just to kind of use all those skills that you learned last time. So I'm going to show you a bunch of kind of visuals because this sometimes gets a little bit confusing for folks. So they'll talk about concordant elevation and concordant ST depression. Okay. They'll also talk about proportionally excessive discordant, right? These slides are also available live in the fast lane. I pulled some of these visuals from because I think that's actually a fairly good site to explain that. I actually think it's probably the best site for explaining that. And it kind of goes through things in a relative stepwise fashion. So I strongly suggest that you take a look at that site as well. So just kind of reviewing concordant ST elevation greater than 1 millimeter in greater or equal to 1 lead. Concordant ST depression greater than equal to than 1 millimeter in greater than 1 lead of 1 through 3. So 1 through 3 are important leads to remember for these criteria. And then the final one is proportionally excessive discordance. So that means opposite side, right? Opposite of ST elevation in greater than 1 lead with ST elevation, right? That's STE as defined as greater than 25% depth of the S wave. But so let's just kind of look at some of this. All right, so let's go by stepwise fashion. So we have a left bundle or something that's pace because we see it on the pacer spikes, right? So this is what they mean by those ST segments, concordant or discordant, okay? So for the first one, right, we have an upright predominantly upright or positively deflected. And then we actually have this ST segment that's negatively deflected. This ST segment predominantly negative, but then the T wave is predominantly positive. So that's kind of normal for left bundle and paste. Okay. And then this is kind of reviewing our criteria again. So if we think about kind of that being kind of our normal for a left bundle, and we're thinking about our criteria, what I'm going to do for you actually is, oh, you know what? I can't copy it that way. I was going to copy and put it in the chat. What do you guys think about this one? So let's take the first point. So concordant ST elevation greater than 1 millimeter in one lead.
Lead one.
Yeah, it just in one lead. If we're kind of looking for a pattern STEMI.
Oh, it's discordant, right? Because we have the primary um, S wave, and then you have the T wave going positive.
Right.
So, and then when I blow it up, and you look at where the J point is, if it's discordant, it should be 25% of the preceding S wave.
Yep.
And it doesn't appear. It's only about 2 boxes,
Yeah.
2 millimeters. And I mean, based on that, it doesn't look like it's near 25% of the S wave.
Okay. What kind of rhythm is this? Let's just kind of go over what you think it is.
Ventricularly paced.
Yep. Good. Ventricularly paced. So if we were applying those criteria to something that's ventricularly paced.
Proportionally excessive discordant ST elevation.
Yep.
Like V3.
V3?
Yeah.
Yep. What about 2? What do you think, Abe, about 2?
V2 probably also.
Yeah, exactly. Okay. All right. So it's the hard thing about this is just getting used to the kind of the concordant and discordant when you see something that looks just so kind of wide and weird. Okay. All right. So if we kind of go over where you could apply these rules, right? Kind of I broke it down simply. There's also a little bit of rate in here as well that we don't talk a lot about, but ideally these rules are applied to a rate greater than 60. It's hard to apply them for rates that are less than that. They have to be ventricularly paced. So that's not atrially paced. You're not going to see a pacer before that P wave. It's really, they could have a both atrial and ventricularly paced, but it really only applies if they're ventricularly paced, left or applying it to a left bundle morphology. So what you're going to be looking for is this significant progression of ST and T wave changes. So other things to kind of consider is massive ST elevations greater than 5 millimeters in 2 through 4, and then proportionately greater than 25% of the QR depth. And then discordant ST elevations in 2, 3, and F and 5, significantly more pronounced. And then if we had a kind of a prior EKG as well. And then another clue to think about it as ischemic or ST elevation in left bundle or in paste is that concordant ST elevation in 1 and in V6. So that's where 1 and V6 are helpful. All right. That was a lot. We're going to take a quick break. And then I actually have another brief thing on action potential we could do that very quickly, or we can just go into just some more 12 leads. You guys have to tell me what you want to do.
We can
Action
do the
potential.
action potential.
Okay, you want to do action potential quickly?
Yes.
Okay, perfect. All right. 3-minute stretch, and then let me just load that up. Okay, we're going to gather back. So this should also be available for you on the Moodle. This is a quick hits. So I'm not going to put you under the spot to answer all the questions. But what I am going to do is similar to what we did with the Kahoots, but without all the Kahoot music, because after a while that gets a little dull. I'm going to have you think about what the answer would be if this was a test question. Okay, so it's a quick little quiz yourself on this stuff. We're going to go through it quickly so we can get to some more EKG stuff. Okay, what are the 5 phases of a cardiac action potential in the ventricular myocytes? Again, so you don't have to call out an answer, but I want you to write it down, text it to yourself. Right, think about the 5 phases. All right, now we're going to go to the answer. Okay, so we're counting phase 0, and that's how we get to 5. So
MD1, you're not sharing.
Ugh, rats. Thanks, Jay. All right. I have to do that at least once a day. Okay. Am I sharing now? Fabulous. Okay. Thanks for the correct. All right. Okay. What are the 5 phases of a cardiac action potential? And we have our answers. So we're including phase 0. That's how we get to 5. Okay. So we have phase 0, rapid depolarization. So that's the big electrolyte there is potassium. Okay. Early repole caused by transient potassium. That plateau phase that you guys were asking about before, maintained by calcium influx and potassium efflux. So calcium in, potassium out. And then that further repolarization phase really continues with the same potassium going out. And then phase 4, we get to resting membrane potential. And we start to kind of readjust and all those ion pumps go. Okay, so just a quick review, right? And the important thing to remember here is how the QRS kind of lines up and how the T wave lines up to that, right? So we have in the first phase, we have that depolarization of the sodium current, right? Then we're getting to that plateau phase, right? That's part of our QT segment, right? And then our further repolarization from the potassium. So that's why if we think back to our first things that we did together, we talked about high potassium and low potassium, right? So that's how you can see how potassium has such an impact on that T wave. Okay. One more time, kind of giving you a picture to kind of overlay. So we have the P wave, so that's atrial depolarization, the QRS ventricular depolarization, and then that ST segment, right? So anything that happens with the T wave and those ST segments, right, that have to do with potassium, but also have to do with calcium. Okay. So this slide is a good visual representation, right, of all those ins and outs, right? So we have phase 0 with the potassium in, right? We have that little green sodium going in, little green potassium going out. Then we have phase 2 here with the calcium in purple and the sodium in yellow going in, that potassium continuing to go out, equalized in phase 3 by a little bit of sodium and potassium sodium and calcium going in, and then that potassium continuing as a potassium efflux. Okay. Which ion is primarily responsible for the rapid phase 0 of the cardiac action potential?
Sodium.
Fabulous. All right, so it's sodium. Rushes into the cell, causing a steep rise in membrane potential. All right, our next question, which you can all answer internally. During the plateau phase, which two ions are involved in maintaining membrane potential? And we're going to have everyone think about it, and then we're going to go to the answer. Calcium and then potassium, right? So calcium influx keeps the cell depolarized, while potassium efflux prevents excessive depolarization. Okay. What effect does increasing extracellular potassium concentration have on the resting membrane potential? Super important for hyper K. So think about what effect does an increased extracellular potassium have on the resting membrane potential? Okay. It reduces the resting membrane potential, making it less negative, leading to increased excitability, right? So that's why anybody with a really high potassium can potentially have increased excitability, and that leads to further dysrhythmias. And if you like a visual, right? So we've kind of taken our regular action potential in the solid line, and then we've taken a hyperkalemic one and see how it slopes a little bit more and then is also much shorter. Okay. What type of cardiac cells have different action potentials with automatic pacemaker activities? This is a two-part question. And how does their action potential differ? I'm going to think about that for a minute. And survey says the pacemaker cells. Okay. So the pacemaker cells in the SA node generate spontaneous action potential without external stimulation. The ventricular myocytes, their depolarization relies on slow sodium influx. It actually is called funny current, and calcium influx rather than rapid sodium influx. Okay. Arrhythmias. Since the action potential controls the heart rate, any disturbance in an ion channel can lead to abnormal beats. I think we kind of know that. All right. So if we think about fast, slow, and fib from the action potential, we think about low heart rates, right? can result from impaired pacemaker activity, so something that's going to be blocking them. So that could be ischemia. That could also be drugs impacting that. That also could be age and other fibrosis in that part of the heart. Fast heart rates, so tachycardias may occur when ion channels promote excessive depolarization, and then fibrillation when it all goes bad, when cardiac action potentials fires kind of out of sync. Okay. So if we think about things that, if we were going to set up a test question, can potentially impact, we have talked a lot about electrolytes already, but also reminding us that ischemia, right, caused by lack of cardiac flow through the coronary, lack of flow through the coronary arteries, oxygen starve can actually change an action potential as well. Okay. Now, there are also other things that people just have congenitally, right? So things like long QT syndrome and the whole other family of things that they call channelopathies, right? So things that have to do with conduction channels. So this is showing you a picture of a long QT, right? And the action potential is really extended for that, and that has to do specifically with those types of potassium currents and potassium channels. What if I had someone who had a long QT syndrome? They said they call 911, they were not feeling particularly well. They had a couple episodes of vomiting, and they said, by the way, I have long QT syndrome. What drug would I not want to give them?
Zofran.
Zofran, perfect. Okay. Now, if you also have these long QT syndromes or other problems with your potassium, the concomitant having a low potassium is actually particularly troubling for these folks. They actually don't deal with it as particularly well. Okay. All right. Now, other things that can affect your action potential in heart failure, chronic stress on the myocardial sites can cause some electrical remodeling, and that's why people with particularly more profound heart failure, ejection fractions less than 20%, are at relatively high risk for having a cardiac dysrhythmia, and that's why we'll frequently implant them with an AICD just prophylactically. All right. Just another visual to kind of go over all of this, right? And there's a term here that you should probably know, right? And it's ERP and RRP. Anybody know what they mean? We haven't introduced this one before, but
Something repolarization.
something repolarization, absolutely. So if it was a test question, right? You'd be halfway there, right? So I'm going to have you guys look that up, right? Because you'll remember it better. So you're going to look up BRASH, and then you're going to look up ERP and RRP. Okay. All right. Another way of just kind of thinking about is thinking about now, if we have action potentials, thinking about where drugs work on action potentials, right? So class 1 drugs are all things that have to do with sodium channel blockades. And those are things we carry in our drug box. Lidocaine is the kind of the classic one, right? Things that people get at the pharmacy, flecainide and propafenone, or flecainide and econide. Things that people don't use that often would be things like quinidine and procanamide, right? We're going to bop on over to class 2. Class 2s are our beta blockers. They actually work a little bit more on that phase 4 all the way to the right. You see that class 2 box, the blue box on the right. Then we move to our class 3 drugs. So they're kind of classically thought of as potassium channel blockers. The main one that we think about is something we carry, amiodarone. but another drug that you've probably seen patients on, it's sotalol. It kind of, when you look at the name, it looks like a beta blocker, and it's a little bit like a beta blocker, but it also has impacts on those calcium channels as well. Sorry, potassium channels. And then we get to our class 4 in the pink on the top in phase 2, where we have most of the impact of our calcium. We have our calcium channel blockers. The classic ones that relate to us are verapamil and diltiazem. They fall into a class of non-dihydropyridine calcium channel blockers, and they'd be in the AF protocol. So I'm going to show you that now with some pictures attached. Okay, so if we go to all of our class 1, so sodium channel impacting drugs, it really has effects on that part of the action potential. So we see in all these pictures, right, it has kind of that dotted line has moved over to the right. If we go next into our class 2 drugs, right, and to remind everyone, our class 2s are our beta blockers all the way to the right here. Oops, sorry. Let's say our class 2s, right, are going to cause an increase in the PR interval. Therefore, they're going to give you a little bit more bradycardia. Our class 3 drugs is really the main one we think about is amiodarone. Going to increase action potential duration, but also prolong repolarization. And then our class 4 drugs, so those are our calcium channel blockers. They're going to cause that slow rise of the action potential because they're working on that plateau phase, and then prolonged repolarization of the AV node. All right, so you survive that, and now we're going to get into some more EKG stuff. So just give me 3 minutes to reload, and I'll be back with you. All right, everyone, you ready to come back? And we're going to do some cardiogram jeopardy. This was prepared by the physician group. Dr. Weber presented this the last time, and we're going to go through it. It has a bunch of good tracings that have some good kind of ways to remember things. So we have a 68-year-old not feeling well. You arrive, you are the ALS providers, bradycardic.
If you're
Oh,
sharing, you're not sharing.
oh, one more
Sorry.
time. No, I need you to tell me. All right, am I sharing now? Fabulous. Okay. I always say I do that once a day, but now we're up to twice. Okie dokies. Okay. So she's bradycardic, she's hypotensive, and this is her EKG. You want to take the rhythm strip first? It's on the bottom. Anybody want to be brave? do a shout out for the first one?
I'll try.
Idioventricular.
Idioventricular. Okay, I heard idioventricular. Michelle, what do you say? You were going to say something too.
Hold on. Abe started speaking, so I muted. I was saying I would try it, but he started speaking.
What's that again?
No, Abe took it first. I said I would try, but Abe spoke
Oh,
first.
okay. Abe went first. Anything else?
You got some PT waves.
Fabulous.
Yeah.
All right.
So little
Anything else?
hyper K.
Okay. What else is missing?
E waves.
Right. Okay. So this is hyper K. K is like 8 or something like that, and in this patient, right? So the reason I like this tracing, right, is similar to the ones I showed you as kind of the example, right? V1 and V2 don't look particularly remarkable, right? And you can see a little bit in lead 1 and then definitely in 6, but most of the peaking is actually in more of the precordial leads, but the inferior stuff is not super remarkable. So just kind of giving you another visual representation about the different ways that hyper K can present. All right. Treatment,
1 gram of calcium.
calcium. All right. So the next one. Bystander calls 911 after they witnessed a 15-year-old collapse while playing basketball. He's now responsive, has an eyebrow laceration. Those are his vital signs. You are the ALS provider. You appropriately decide to get a 12-lead EKG despite his tender young age because it's part of the workup for syncope. And you have this.
Definitely a supraventricular rhythm.
Mm-hmm.
Um, I
If you looked at the rhythm strip though, do you see
I don't know if I would call that P
P
waves.
waves? Okay.
Oh,
Are those delta waves?
yeah.
They are.
So WPW.
Yeah. So WPW. What else do you make about this EKG? It's not just WPW. I mean, it is WPW, but it's
There's
some,
some LVH.
yeah, there's crazy voltage, right?
Hmm.
Just like crazy voltage, right? If you look at lead 2, it's like um, particularly predominant. So if you see something with that really, really high voltage, what would you think about?
What the heck, Malachi? What are you talking about? So, like, if you ever
Probably has some enlarged.
buried 9 feet deep,
Person probably has an enlarged heart,
Okay, yeah.
left
So you'd be
left side particularly.
Yeah, so you'd be thinking about some type of left ventricular hypertrophy. Exactly. All right. So what if they went up to 180?
Are they mentating well, decompensating?
Okay, that's a good answer to the question. So let's say they are not mentating well and not perfusing well.
Just synchronized cardio rate.
Okay. All right. Let's go to our next one. Okay, so this is a 65-year-old complaining of chest pain. You find the patient comfortable on his couch. He says he took aspirin and some nitro. You do your due diligence and you get a 12 lead. And that's what it looks like.
I take a shot at it.
Sure.
I would just because of these deeply inverted T waves. I first thought would be Wellens.
Okay. What does Wellens mean? And can you describe what that pattern is?
Um, I want to say it's. I know it's the worst of the two because you have one that's almost biphasic. I think the biphasic is type A, and I think the deep. I could have it backwards. I think the type B is the deep inverted T's.
Okay.
Um,
What's the significance? I'm going to push you a little bit because I think you know this. What's the significance of this?
it's supposed to be a sign of potential stenosis of the LAD.
Perfect. Okay, so critical LAD stenosis. So this will be an ALS patient. All right, so our next one, case continues, you get this EKG. You took the patient ALS and you get this EKG. In the back of the truck, the patient says, I just feel sweaty. Don't like to feel sweaty, he says, and I feel sweaty. Well, if
Is
you were
this
going to describe,
oh,
yeah, Benny, go ahead.
um is this Brugada?
Um,
T the way we're lower than the T wave, or I'm probably
well, let's say we're going to stay with the same presentation, right? The guy's got some chest pain. He had this EKG before, right? That looks like it's ischemic. He has those deep biphasic uh, T waves in the anterior lead. So we're going to call it Wellens and we're going to call it a
Mhm.
critical LAD stenosis. And then he does this. And you're on the radio and you're like, wait, wait.
Okay, so
Just describe it. You don't have to say, but just kind of describe it. And then,
well, it looks like he has looks like there's some elevations in V1 to 3, 4,
yeah,
and
perfect.
5.
Okay.
Yeah, so MI, anterior
Okay.
septal MI.
Okay. And then give me the rhythm.
It is sinus.
Yeah. I think I see a P wave before QRS. Okay. So
Yep.
now we're gonna call it a STEMI or not?
Yes.
Perfect.
We call it a stomach.
We're
Yes.
gonna call it. Okay. All right. All right. Let's go to the next one. Okay. So another person calls 911 for chest pain, shortness of breath, and feeling like their heart is racing. A7 finds them in moderate distress to Kipnick, but maintaining his airway. Those are his vital signs, remarkable for a really high blood pressure and a uh, relatively elevated heart rate. But his heart rate's kind of going up and down. And then you get and you ask the patient, sir, has anyone ever told you you have a left bundle? And the patient says, why, yes, Benny, I have been told that I have a left bundle.
Garbosa.
Yeah, I was gonna say use Barbosa's criteria.
Okay, all right.
Uh,
How about that?
so looking at V2, it has a concordant ST depression along with
Yeah,
the S, but
yeah,
it's more than 1 millimeter.
right,
And then if you also look at V5 and V6
yep,
that have, again, concordant ST elevation greater than
right,
1 millimeter in
right.
those leads also.
And the last slide I showed you when I just was throwing other things out about Scarbosa, or modified Smith Scarbosa, we said something about a lot of ST elevation in B6, right? And we said greater than 5 millimeters, right? And I think that would count if I'm counting boxes. 1, 2, 3, 4,
Yeah.
5. Right. All right. Okay. So just a quick review, right? So,
I'm sorry. I'm sorry,
oh,
Doc. Can you go back to that
back.
EKG?
Yeah.
Yes, please. So I know Michelle said that you have the ST depression V2. In is it supposed to have like is this concordance? Where's the second one?
The
Because
second
I
one.
see. So is it just the ST elevate ST depression in V2 and the
Well, yeah, and we're supposed to have
elevation?
two leads. So,
Yeah. So which
so
one's
I'd say
where's the?
V2 as well. V2 and V3, right?
Oh, okay. Yep. Okay.
Yep.
I see what you're saying. All right.
And
Uh,
then we're gonna go to this one just to kind of as a quick reminder, same visual, right? And that's the expected discordance. And then we're going to go to this visual, right? That starts to look like our patient's 12 lead, right? So if we go back, right? What's that, Abe?
He has all three criteria.
He has all three. Okay, so he has, right? So he has all these criteria, right? And he has the greater than 5 millimeter, right? And we can see that definitely in V5 and V6, right? And then in our predominantly upward bundle, we want ST elevation. We want to be able to see that. And where do we see that? We can actually see that in lead 2, and we can also see it in AVL and a little bit in 1. Okay. And then in V1 through 3, we have predominantly negative in this one, and then we want elevated there. So predominant, yeah, a little bit. All right. Okay, so we're gonna give you a couple more visuals. So if you kind of focus on the gray box in the middle, and then the yellow orange box on the right. Okay, so if you were adding a point system, there's also the kind of the standard Scarbosa, not the modified Smith one. This is what they mean by the point system. So the first criteria is ST elevation greater than 1 millimeter in any lead with a positive QRS. So that would be 4, 5, 6, 1, and L, right? So so normal would be no ST elevation. Ischemic would be ST elevation. 5 points there. ST segment depression greater than 1 millimeter in V1, V2, V3, right? Definitely sagging there on the orange side. All right. Sorry about that. You guys, I lost you for a New York second. I don't I don't know if you lost me, but I all of a sudden lost internet. So, all right. So then we're at the last one, right?
Don't
So,
forget to share MD1.
oh yeah, so I have to reshare again. All right. Doggone it.
That's
Okay.
number three, but who's keeping count?
It is, well, I'm not counting this one because I lost internet. So it had to all reset. So I guess I could count it or not. So number three for the day. All right. It's almost the end of the day, so I could probably make it. If I had four, it'd be terrible. All right. So we're looking at ST segment elevation. So the final one worth 2 points. ST segment elevation greater than 5 millimeter in any lead with a discordant QRS, right? So this is actually pretty easy to find, right? So if we looked at the gray box on the bottom, that is predominantly negative, and then that T wave and ST segment is predominantly positive, right? What they're saying for scarbosa is we're still going to have that elevation, but now we want greater than 5 millimeters in any lead with that negative QRS. All right. This is good. We're going through all the stuff. Okay. So you have a 18-year-old complaining of palpitations after getting into a fight with his girlfriend. He's a well-appearing male. Those are his vital signs. You decide that because you are the best, most diligent medic, even though his young age, you say, I'm going to get an EKG. And he said, I had palpitations, but now they're better, and it's all due to this fight, but my mother made me call.
Um, I would think about it. I would say it's not. It doesn't look like it's quite greater than 120. Let's say LBH, and it looks like he has some slight depressions in V5, V6.
Mm-hmm.
One maybe a little bit in AVL. That
All
would be
right.
my thought.
Okay. I like it. Anything else? Anybody want to add anything? Look at the rhythm
I
strip.
don't,
What do you
I don't see
notice?
anything that meets Scarbosa.
Right. Nothing that meets Garbosa, but good to think about it. You can't find ischemia unless you think about it. What do you guys think about the rhythm strip? Anything jump out at you there?
Or ER?
Yeah, really short PR. Yeah. So now if we
Is it
really
delta
think
waves
about
again?
what's that?
But is that a delta wave? Like the
Yes. So this is another form of WPW. Okay, they call this type B. You don't have to get too upset about type A or type B, but this is just another visual of getting you to kind of look again at the EKG and think about this as a delta wave. You can really, if you now kind of look for that, you can really see it in lead one, but particularly you can really see it in 5 and 6, where that kind of like delta scooping as well. So that's another type of WPW. Really, you're seeing it in these kind of lateral precordial leads. All right. ALS patient?
What are the What are their symptoms?
He had palpitations,
Currently ongoing chest pain.
no
Is
chest pain.
he hemodynamically stable?
He is.
Um, I mean, being a new individual, I would probably sit on him and just monitor.
Yeah, I think that's wise. Exactly. Because we don't know the extent of his WPW, right? We don't know what kind of stressed him into it and if it could recur. Absolutely.
Can I ask a question about that EKG?
Yeah.
Would the WPW be the cause of that LVH phenomenon, or
No, it's probably concomitant, so he could be just um, also have that LVH. Sometimes you can see kind of increased voltage, although you don't really see it in really every kind of traditional lead with someone with a really kind of narrow, thin chest wall, just because you're picking up more stuff.
okay?
Okay. We're kind of almost out of time, so let's go through a couple. All right. So, whoops. Okay. All right. This one didn't have a story behind it. Okay. All right. So case number 6 is a 75-year-old female feeling dizzy, fatigued, ALS arrives. Those are your vital signs. And this is your EKG.
It's a block type 2, number 2.
All right. Tell me why.
It's got extra P waves for some of the beats.
They're extra. Okay. All right. So if
PR
you,
interval.
yeah, go ahead.
I'm sorry, I was gonna say the PR interval appears to be the same. Also, it's not
Hmm.
elongated.
Okay. All right. So if we were going to give it a pattern, right? Sometimes these things come in patterns of 2 to 1 or 3 to 2. What would you say it is? So if we were going to look at the bottom rhythm strip, right, we have the first complex, we have a P wave, right? We have a T wave, and then we have P wave that's not conducted. And then we have a P wave.
It looks like a change in pattern.
Yeah,
Like it
exactly.
goes from like a 3 to 1 to like a 2 to 1.
Exactly. Okay, so it's really kind of changing as well. All right. So if we go back to the rest of the EKG, so we see that kind of um, conduction appearance, what are we now going to do with our patient? What would be the action steps?
Depends on how she's presenting.
Okay. Well, she's presenting dizzy.
What's the heart rate?
Well, you tell me.
Do you know how long the strip is?
Right, so we can, let's say it's kind of standard length.
Probably
If,
gonna start off with some fluids.
okay.
Um,
All right. So, and she got here, right, by saying she felt short of breath, she didn't feel particularly well, right? So even though we have this kind of group beating that is a little distracting, right? We'd still want to make sure she doesn't have any ischemia, right? So we're going to kind of look in all of our leads. I'm actually not particularly fond of that ST segment in V2, right? That looks like has a little bit of scooping there that probably shouldn't be there, right? I'm also looking at AVL. That ST segment looks really kind of flat as well. So I'd be additionally kind of concerned about that. And then I'm going to look a little bit more laterally because now I've looked at L and I'm going to look at 1, and that also kind of looks like a flat segment as well. So I'd be a little bit concerned that there's some kind of concomitant ischemia. Now, maybe she is always in this rhythm, right? But we don't necessarily know that, and I'd just be concerned that she had some kind of further ischemia to her conduction system, and that's why she's in this rhythm, right? She may or may not, but at this point, we kind of don't know. What would you do for treatment? We talked about some fluids. Anything else? Maybe thinking about kind of what would you keep an eye on? Would you think about adding to your treatments? Right, so we've got an IV. Right?
IV, monitor her. We
Yeah.
could, let's say, we could try some atropine.
Yeah, if you really thought she was a little too slow.
Slow. Yep.
Yeah.
And if she started to deteriorate, then basically pace her.
Right. So you maybe think about putting the pads on her. All right. Okay, let's do, oh yes, pediatrics. All right. Kids have hearts too, right? Mom calls for a 3-year-old child who has a fever and a cough. A14 finds the child sleepy, arousable, um, and then kind of gets a little bit more appropriate. Those are the vital signs. And just because you are a good doobie,
Such as the patient is a baby.
3 years old.
Give some fluid.
It's definitely a fast rhythm.
It's definitely fast. Okay.
Especially even for a 3-year-old. I
Yeah.
mean, we're looking at three. That's what 300. Probably
just a little more, less than 300.
less than 300.
Right.
So, is the I'm sorry, I didn't pay attention. Was the baby
Let me go back.
yes. Okay. Fever and a cough. Okay. Sleepy by arousal. Okay. Any I mean probably try some fluids, see if
Okay.
it would break. Because baby not feeling well with the fever. I mean, the fever could spark the heart rate to go fast.
Yeah.
So probably try some fluid to see if we could cool down and slow down the rhythm. See if
Okay.
that'll work.
All right. So maybe get rid of some of the kind of temperature as the driving factor here. So maybe think about kind of if baby's all bundled up, he's not really baby's a toddler. Kind of unbundling, getting temp down. You wanted to do some fluids. In some ways, maybe the act of putting an IV might get the kid to do what?
Vagal down.
Kind of vagal down as well.
Yeah.
Okay. All right. Good. But I think that the one way to think about this EKG is even at that age, that rate is fast. Perfect. Okay. All right. So we'll do one more. Okay. So this is an 18-year-old who collapses during hockey practice, unresponsive, and then woke up without intervention. There's no head strike here. The 18-year-old is sitting comfortably on the bench, wants to get back on the ice. Those are his vital signs. But you convince the patient to get an EKG.
Is this one Brugada?
That one, Abe, you got your Brugada. It is fine. We have found a Brugada for you. Absolutely. Okay. Remember, there's a couple different types of Brugada. We don't have time to kind of go all over them, but just kind of remembering that you'll see it particularly in V1 and V2.
It's type 1.
It's type 1? Okay.
Yeah.
Michelle.
Type 2
Good.
is the elevated saddleback.
Saddleback. All right. You know your brigadas. All right. Well, that is going to end us for the day. I'm going to give you 8 minutes back. All right. Thanks, everyone.
Thank you.
Thank you.
Thank you, Dr. Dyer.
Oh, you're
Thank
welcome.
you, MD1.
Thank
All right.
you.
You guys take care. Bye-bye.
Dr. Dyer, thank you so much. I'm sorry I wasn't as focused in. I'm chatting with the chief at the moment, so.
Okay, no problem.
Okay, great.
I'm
going to stop recording and we will make sure that